Yes, thank you again for the kind invitation. My task is to give a summary on clinical management of cholangiocarcinoma. And as you see below on the slide, this is always teamwork, multidisciplinary teamwork. I try to move. Yeah, there are a number of challenges when you meet a patient with a suspicion of cholangiocarcinoma. Cholangiocarcinoma is worldwide, globally, the second most common primary hepatic malignancy. Globally, about 15% of the primary liver malignancies. The incidence is globally increasing, particularly in Asia, and this is true for the intrahepatic form of cholangiocarcinoma. So it's an increasing problem. I have difficulties to move my slides. This is an overview from the European Network for the Study of Cholangiocarcinoma, recently published. And here you see the differences in the incidence worldwide. For France, you see, for example, 1.3 per 100,000. This is quite low in comparison. Particularly to Asia, these are the green areas where you have clearly higher incidences, and the highest overall is in northeastern Thailand, as probably many of you know. And this is, we think, linked to the liver fluke, Opistorchis and Clonarchis, which may be the cause of cholangiocarcinoma development. Another point in the cholangiocarcinoma is the high heterogeneity. It's not just one tumor type. When you look, we know already for a while that it's not only the cholangiocyte as origin of cholangiocarcinoma cells, but clockwise, also hepatic progenitor cells have been shown, hepatocytes have been shown, and peribiliary gland cells have been shown to be the origin of cholangiocarcinoma. So it is really heterogeneous. And we put these different forms also what regards the localization of cholangiocarcinoma together to one term, but it's probably different tumors. Here you have the distribution as we think it is now globally, 10 to 20% intrahepatic cholangiocarcinoma, increasing in percentage. Perihilar cholangiocarcinoma still the largest group, 50 to 60%, and the distal cholangiocarcinoma, 20 to 30%. Thank you. Another problem is the silent growth. We mostly detect cholangiocarcinoma in our patients at an advanced stage because patients are asymptomatic for a long time. And this is linked to the poor prognosis of the disease. The 5-year survival, these are recent numbers, is about 7 to 20% overall, and that's very poor. We know, meanwhile, multiple risk factors for cholangiocarcinoma, but most cholangiocarcinomas, which we see, develop spontaneously. It's still 80% spontaneous and 20% carrying risk factors. And when we look at the risk factors, this is a table from the European Network Study Group, and you see the red marked risk factors which have the highest odds ratio. We know that from clinical practice. It's choledochal cysts, it's hepato and choledocholithiasis, it's Caroli disease, and it's primary sclerosing cholangitis, and they have enormous odds ratios to develop, particularly intrahepatic cholangiocarcinoma, but also for PHC, for example, extrahepatic cholangiocarcinoma, and for Caroli's disease. Also, other forms of liver disease are risk factors, but not that evident as for these diseases. When you look at this table, you can summarize. Next slide. Yeah, that a common background is the chronic inflammation of the biliary epithelium, and I think we have to improve our screening strategies. And in these patients with chronic inflammation of the biliary epithelium, we probably have to implement earlier screening programs to detect the cholangiocarcinoma earlier. We have that for PHC in our guidelines, but for the other diseases, not yet. There are other risk factors, as you see here. And when you look at the lower part of the table, type 2 diabetes, non-alcoholic fatty liver disease, obesity, hypertension, alcohol consumption, these are all factors which could be influenced, and thereby the risk could be lowered. And this is part of what we think is the reason for increase in intrahepatic cholangiocarcinoma. Now it doesn't work. Thank you. The diagnosis problem, clinical signs and symptoms often appear too late, and the first symptom often is jaundice, but in a late stage of the disease. Serum cholestatic markers and CA19-9 may be increased, but and often are increased, but they are not accurate for the diagnosis of cholangiocarcinoma. CT is the standard imaging method for cholangiocarcinoma, and here you see this early arterial phase where you have the rim of contrast agent around the tumor, and which slowly then comes into the center of the tumor as a typical feature of CT imaging. MRI shows similar accuracy and maybe of added value when you add the MRCP. Otherwise, you see in this series below, slowly from a rim around the tumor stained by the contrast agent, filling of the contrast, typical imaging. Yeah, there is a lot of discussion on the use of FDG PET, but we have to admit that there is no evidence-based additional diagnostic value, although we also use it in selected cases in our patients, but still not enough evidence to recommend it to everybody. Histopathological and cytological analysis is mandatory for cholangiocarcinoma. For example, by brush cytology and intraductal biopsy, and has to be done. Future approaches, just mentioning some of them, biliary microRNAs seem to be promising. Serum CIFRA 21-1 seems to be promising, and so forth. But there is a lot of development, but we are not yet there to recommend it for the routine use. The current management, it's a multidisciplinary approach. I already mentioned that. When patients come to us, the first question is the disease resectable, because surgery is the first choice treatment. And when you look at the whole cohorts, and you will see that later, about 25 to 30% are potentially resectable. And then the prognosis is, yeah, you see the numbers of 2020 from now is reasonable in comparison to former numbers. So then you would proceed with surgery with a curative intent. You have different approaches, certainly, for the different tumors. You perform segmental resection or hemihepatectomy or extended hemihepatectomy for intrahepatic, extended or normal hemihepatectomy for perihilar cholangiocarcinoma, and for the distal cholangiocarcinoma, usually a Whipple procedure, this pancreatoduodenectomy. Criteria of resectability. no extra and hepatic metastasis. Lymph node metastasis should be really confined to hepatoduodenal ligament and one lymph node metastasis. The possibility of achieving free ductal margins on future remnant liver is key. Involvement of portal vein bifurcation is possible. Involvement of the hepatic artery branch to future remnant liver is questionable. The future remnant liver should have more than 35 to 40% of volume of the total liver. And here you see a CT volumetry at the right side of this slide. This is an example from our own cohort from Amsterdam. Studied from 2000 to 2018. On the left side, you see the famous Bismuth-Collet staging, stage 1 to stage 4, and this is now perihilar cholangiocarcinoma only. You see the extent of the tumor coming from the common bile duct and growing into the two hepatic ducts, left and right. The numbers we had over the 18 years, this was a total of 751 patients with suspected perihilar cholangiocarcinoma, 290, more than a third, were initially unresectable, and I think this is reality. 2/3 potentially resectable. We perform diagnostic laparoscopy in our unit. This is also this is discussed, and this is also recommended by the European Network study group. And laparotomy was finally done in 377, so half of the patients. And resected were about 60% of those, whereas 40% intraoperatively they could not be resected. And then you have still 80% were really perihilar cholangiocarcinoma, and 40 were benign lesions, which were thought to be perihilar cholangiocarcinoma. This is one problem we have, how to distinguish benign and malignant biliary stenosis. And one of the diseases we discussed most recently is IgG4-related cholangitis, because when you look at such a cholangiogram, I think 19 of 20 colleagues doing ERCP would say this is just a cholangiocarcinoma. And but this patient had IgG4-related disease, and after prednisone treatment, this stenosis completely disappeared, and he had a normal bile duct system. So it is difficult to make the diagnosis of IgG4-related cholangitis, as only 70–75% of the patients have an elevated serum IgG4, and we are far from being there to make an early diagnosis of IgG4-related cholangitis. But we have to think about it. For every patient who goes to surgery, we should determine the IgG4 before. Then the next slide. Thus, the misdiagnosis is common in these patients, and 1/3 of IgG4-related cholangitis patients, I have seen more than 160, the last one today, and 30% of them already have undergone major surgery, so hemihepatectomy or Whipple's procedure, and then the IgG4-related cholangitis was diagnosed in the removed organ tissue. Next slide, please. We looked in our patients from Amsterdam from 84 to 2015. Is cholangiocarcinoma mimicking lesion really a problem? And in 15% of the 323 resections, there was a benign disease detected afterwards, and we worked all the tissue up, and in 42% IgG4-related cholangitis could be proven, and also the others had fibrosing cholangitis, and we think the majority also of the others, but some of them were very old and we had no information 30 years back, probably were also IgG4-related disease. So it's really a problem. And we have to find strategies to detect it earlier. Before surgery, preoperative biliary drainage in resectable cholangiocarcinoma. For perihilar cholangiocarcinoma, we do that, particularly in those who already had cholangitis or who will lose the majority of their liver volume, so who will end up with less than 50% future liver remnant. And this is because of improved liver remnant function and regeneration. We then tested in a so-called drainage trial, a multi-center trial. Should we do that by ERC, by endoscopic route, or should we do it by PTC through the skin? The result was surprising. We had a higher mortality in the PTC group, this study had to be terminated early from the supervising team, and is published in 2018. So we do in our center, we do the endoscopic route to do the preoperative biliary drainage when needed. Next slide. This is different from the distal cholangiocarcinoma. Here we have data from a study which our center led in 2000 and published in 2010. And these patients were patients with pancreatic head carcinoma, and there was also looked, do we need peribiliary drainage, preoperative biliary drainage? And the answer was no. There are too many complications in the PBD group, in the preoperative biliary drainage group, so we don't do drainage anymore, also for distal cholangiocarcinoma. Next slide, please. And these are our numbers from these years. You only have to look at the black line in 171 resected patients with proven perihilar cholangiocarcinoma, median overall survival 46 months. Next slide. So adjuvant chemotherapy is now recommended. This is the so-called BILCAP trial, which showed a benefit for 6 months of capecitabine after curative surgery with a hazard ratio of 0.75 for survival. Then we come to the other side, those who are not resectable. The prognosis is much worse, as you can see. When we consider treatment, we first have also look at the performance of the patients, the performance status of the patients. And when patients are most of the day in the bed or are not able to move, we do not offer systemic chemotherapy. But systemic chemotherapy, first-line treatment is gemcitabine and cisplatin. And this was the landmark study from 2010 from Dr. Valle and colleagues. And it clearly showed a benefit in survival in the combination of cisplatin, gemcitabine versus gemcitabine alone. And still today, we have nothing better, and we treat our patients with this combination. Second-line treatment. Next slide, please. Yeah, second-line treatment is a FOLFOX protocol, which also shows benefit in patients for palliative treatment of patients with cholangiocarcinoma. Next slide. One of the problems, you don't have to look at this table, it's just for looking afterwards to it. But we know, meanwhile, a number of mechanisms of chemo resistance, because many patients get during treatment resistant to the chemotherapy. And you see in the upper line several mechanisms by which chemo resistance appears. This is impaired decreased drug uptake or increased drug export, and other mechanisms which are activated and whereby the tumor cells get resistant. And there's a lot done in the past, and we have to have this knowledge also for the planning of future medications. Next slide, please. Local treatment options. This is what is used in trials at this moment, prospectively, together with systemic chemotherapy, often hepatic arterial infusion chemotherapy, photodynamic therapy, again, new trials, chemoradiotherapy, selective intrahepatic radiotherapy, SIRT, and so forth. There is a lot ongoing at this moment, but we can't at this moment report results which are already can go to clinical practice. Then also others like external beam radiation therapy are under study, but we can't give results at this moment. Immunotherapy, another addition to systemic therapy, possibly promising, but we have to wait for phase 3 results. And the next, and this is one other very promising approach, but we have to wait. The molecular profiling and targeting of actionable mutations and amplifications or amplifications. We know that there are particularly these genes are often mutated in cholangiocarcinoma, like the fibroblast growth factor receptor 2, or MMR, DNA mismatch repair, and others, which can be targeted by specific monoclonal antibodies and other treatment strategies. This is future. But the first trials are going on also in our center, and this is probably, I hope, hope-giving for the patients in the future. This is the summary. I conclude. Surgical resection is a potential curative option for cholangiocarcinoma in 2021. Adjuvant chemotherapy with capecitabine for 6 months after surgical resection is recommended. Liver transplantation, I didn't mention it within the 20 minutes, is a potentially curative option for intrahepatic cholangiocarcinoma, small, and perihilar cholangiocarcinoma under strict limitations. This is the example is the Mayo Clinic protocol. And everybody should follow national protocols and under strict limitations. Cisplatin gemcitabine is the standard of palliative care chemotherapy for patients with unresectable cholangiocarcinoma. FOLFOX can be recommended as, and local and systemic therapeutic approaches are under development. And that's my end. Thank you for your attention.